Acute is, like we talked about before, primary damage is to the anterior talofibular ligament. You also have to look at the calcaneofibular and the posterior talofibular ligament. So yeah, you'll have that with swelling, ecchymosis, and bruising, like we talked about, the grades 1, 2, and 3. Something, here, someone hop up on this table real quick. I'll show you something. You have bad ankle,
Yes.
right? Do you have laxity in it?
I'm not sure. Not exactly
Here,
sure.
we'll see. Sorry. This is the easiest table, I guess. Yeah, faces. Come around if you guys can't see. Okay, so this is kind of, skip that. Yeah. Which one? This one was the one? Okay, so this is kind of like a way to look at or assess an ankle sprain. So when you're going to be evaluating later on in your careers and doing great things, you're going to, whenever you evaluate, you kind of recreate the injury, right? So if they say they rolled their ankle, you're going to, what you're doing is recreating that. So you're putting them in a stress position. So this is the most common way to roll your ankle. Plantar flex, inversion, ankle sprain, okay? And then you can also do it like, so that ligament is the ATF, that's what this one's affecting. When you're in the neutral position, it's the CF, calcaneofibular ligament. And then sometimes you can even get in a dorsiflexion position, and that will be your posterior talofibular ligament. It's all about the anatomy. You're thinking about picturing which ligaments, which structures are being bothered. Okay, so if I put it, does that even bother it? Or no? No. So he doesn't have too much laxity compared to the other one. That's another thing. You always want to look at like bilateral comparisons, but wish I had someone to show you, but you'll be able to feel difference in laxity in some ankles versus not. So management, you want to manage the swelling, do compression. You can fit them with an ACE wrap. Always wrap this little proximal. Why? What do you guys think that?
Do an ace ring.
Why would we think about what you're doing? If you're wrapping proximal to distal on a swollen ankle, or swollen knee for that matter, what is that going to do? Yeah, it's going to drop the swelling to the toes, or to the ankle for that matter. And then, like we talked about before, work on balance and regaining proprioception. Okay. Lateral ankle sprain complications. That posterior tibialis can be affected as well, and it can shut off after an ankle sprain. That posterior tibialis comes around and wraps around the ankle, and sometimes they'll even have a tendinitis to that as well, and they won't swell nearly as much, and their pain will be located a little bit differently with the posterior tib. They'll complain more of pain towards the back, maybe even like Achilles tightness, and it'll wrap around the front and goes onto the fifth neck. So determining the difference in the anatomy is a big key there. And talar dome OCD, and that's where the talus and the medial malleolus end up hitting each other, so you're getting a contusion of the bones because there's so much of an inversion stress on the ankle. So if you think about it, like this side is your talus and this is the medial malleolus, because you're inverting that foot, it's just banging those bones together. So they can get a lot of referred pain to that area, sometimes even more than just on the lateral side. Chronic instability, just increased laxity in the joint, usually due to amount of recurring ankle sprains. About like the peroneus brevis tendon, and it could require surgical repair. I've never had an athlete where they've had to do this, but have you, Reed? No?
It's pretty involved to get them to where it's putting more than, I think, 3 drill holes to kind of weave the tendon in from your ligament, so it's a pretty involved recovery.
Okay. So at what point did they need the surgical repair?
I mean, this girl had been doing this for years. She was a sophomore in college by the time we got a hold of her, and it was just chronic, recurring. We couldn't tape it tight enough to keep it stable. She'd still keep rolling it. It just gets to the point that you make a decision that you're going to have it just because you can't stay competing. For the most part. Most doctors will put you through a whole heck of a lot of passive or active rehabilitation before they'll even consider the surgery, hoping that increase in the functional stability is going to do some good, because it's so involved to try to mess with it.
And let's look at the lateral ankle reconstruction. Kind of that's what you just talked about, huh? Like where they drilled the three? Yeah. Okay. All right, now on to quote-unquote high ankle sprains, syndesmosis. So you're going to have external rotation with this and with eversion as well. And it's not really that high up whenever they're referring to high ankle sprains. It really will just be like right in here is where they're going to be hurting, like. And what you want to do is make sure you want to rule out a fracture, of course, and if you follow the Ottawa ankle rules, which is right up here, to decide on an x-ray, which we never decide on x-rays, doctors always do that. But any pain around the malleolus, medial, and any bone tenderness as well. 6 centimeters of the posterior edge of the tibia or the tip of the medial malleolus, or bone tenderness along the posterior edge of the fibula or tip of the lateral malleolus, and then an inability to bear weight on both immediately and in the emergency department for 4 steps. On the fibula, that's because, like we talked about with lateral ankle sprains where you can get the bone contusion, you can also get that with the fibula as well. And that's it. Ankle sprains. High ankle sprains, like I said before, they can usually take a little bit longer to recover, and they're pretty nagging. They're pretty annoying. Like, once an athlete has it, it's going to kind of last the remainder of the season for the most part. And when you're talking about taping techniques, when you guys learn how to tape an ankle, we have these things called horseshoes, and you're supposed to wrap it from medial to lateral, and that's a way of preventing lateral ankle sprains. And with a high ankle sprain, you don't actually want to wrap it. You would think, so high ankle sprain, they did it by eversion, so you wouldn't want to stress the eversion, right? By wrapping it medial to lateral. Well, some people think, well, maybe I should wrap it lateral to medial. I never do that. All I do is just bring it like immediately, like stress both sides at the same time, because you don't want to put them in a position to roll their ankle laterally, right? Because that's the more common way of doing it. So just kind of stabilize both sides at the same time. So, medial sprains affects the deltoid ligament. I just kind of talked about the taping. Just remember to, when reversing the lines of pull, just making sure they're the exact same. Okay. Tarsal tunnel syndrome. This is where that medial flexor retinaculum gets inflamed and is compressing that tibial nerve and artery, which is causing that pain, tingling, numbness to the foot. So it can radiate into the foot. And I'm sure you guys have heard of carpal tunnel syndrome. Same thing in your wrist. This is the same thing, except in your foot. So some of the problems with this, it could be like a lack of arch support, and you can put in orthotics to support that medial arch and hopefully take some of that pain off of it and relieve some of the symptoms. Fractures, dislocations. This can occur with the malleolus fracture. It'll be like the ankle flexed in plantar flex position and forced eversion or inversion. Ligament laxity will predispose you to this injury as well.